Hello.
Hello. Share screen communication. Screen.
Yes, we can hear you. We can.
Share button. The online averagely credit is normally in silent shape. There are no facial responsible. Lips are the silent. Eyes, ears normal, and throat also normal. Upper limb, no deformity. Upper limb body, nails have silences. There is no clubbing. There is clubbing. Irregular clubbing was there. And spine also normal, chest symmetrical, there is no deformity, abdomen also normal, and genitals also normal. On system examination per abdomen, for inspection, while symmetrical, palpation soft, there was hyposplenomegaly, liver was 4 centimeter, and spleen was just palpable. Vasculation normal, bones not served. And on respiratory examination, A and T bilateral equal, bilateral base was there. On cardiovascular system examination, on inspection, symmetrical normal chest wall is there. There is no precordial bulge. Tracheal position is normal. Apical impulse is normal. There are no neck veins involvement. No visible pulsation are seen. On palpation, tracheal position normal. Apical impulse is hyperdynamic. There are still present with systolic and no parasternal lever there. On auscultation, pansystolic one is present in bilateral parasternal area as well as to heart. CNS wise, patient is conscious oriented and TPR also normal. 12 hour test is normal. Just analyze the findings. Means what does the findings tell you? What does this normal tell you? Come on, murmur in the parasternal area means what? You know, murmur in the parasternal area. Parasternal area which valvular area comes from. That is second space. Okay. And go down. Well, is at the apex, no? So this is tricuspid area. But we are not thinking of a valvular lesion here. So therefore, we will look at it as a, in terms of shunt, what is the meaning of a parasternal murmur? You have written where in the parasternal area, which space, second, third, fourth? Third space. So it could mean a shunt, but then now complete the sentence further. That suppose it means a shunt. What is your problem here? That shunt alone cannot explain the cyanosis, no? The shunt is left to right.
It cannot explain the cyanosis. A right to left shunt does not cause a murmur. In fallows, when you have a right to left shunt, that shunt does not cause a murmur. So you have to think that this murmur is either originating from something else or there is something more than a shunt. It's not just a shunt for which we are not getting any clinical signs just now. We, oh, there's a thrill. Sorry, I missed that. I missed. Yeah. Thrill. First, tell us the importance of thrill, then you'll understand why sir is asking where is the thrill. Is organic. So one is it means the murmur is organic. What else? A thrill always tells you that the defect is anatomically underlying that area. Okay. So now that is why it is important. Where is the thrill? So where is which area was the thrill? Mid clavicular line. So anyway, it's not really making us closer to the diagnosis, but we just know that there is a definite defect there, which is having turbulence across the defect. That's why a murmur. And our original analysis that this is not just left to right shunt because there is cyanosis. So this is possibly a mixing lesion. This child has been having failure right from beginning, right? Okay.
Position, but it is hyperdynamic. So what does hyperdynamic mean? And what does the normal apical impulse mean? Is there a cardiomechanic? Possibly no, because the apical impulse is normal. So here is no cardiomechanic. Okay. When we are talking about a cardiac failure. So again, quite not congruent with what history talks about, what we have been discussing. So this may like an undergraduate. Okay. First tell me the site, position of apex. Think of what kind of apex it is. Here you have not said, you have said normal. Okay. So we believe that it's really normal. Then the normal site of an apex is unlikely to be having a normal characteristic. Okay. So again, the problem. But can right-sided heart enlargement not have an apex at a normal place? Left-sided, yes, down and out. What about right-sided? No, right? Now, in a small child, that up or may not be so right. Okay. And why is that? After all, one chamber is enlarged. That must be enlarged. How can a right side enlarge? The pitchment is not shifted. That's why it's enlarged. No? So the question is, anatomically, where is the right side shifted? Is it on the right side? Or is it on the left side?
Anatomy of the heart actually in the body. Yeah, so it's right and left, but it is turned like this. So the right is in front and left is behind. Right?
So the right ventricle is inferior. Okay. And that's why you get signs in the epigastrium. It's inferior. The left border is left ventricle, but the right border is not right ventricle. Right ventricle is below it. And therefore the heart may appear normal, but still hyperdynamic, and as you said, apex is a little turned up. Okay, so we need to know exactly what it is. But that means this is the right-sided problem, but we are thinking about the left-sided problem. So I think this is not unusual. Okay, when we examine a child, the findings are often not the same that are being presented. We just want to bring up. Child is not here.
Actually, they shifted to from PSU.
Okay. They can
He was an oxygen, minimal water support was there by PSU.
when laboratory finds something unusual, they put an asterisk and write down below, say, checked again. That means the man has said, oh, something is unusual, and he's telling you, but I have checked it. We must also do that. Something unusual, not correlating. You must check the history again and check the findings again. I think we must make that happen.
Impression 1 year old female child, fourth birth order, born of non-conscious marriage, birth and development of human till date, with history of multiple episodes of cross-encoding path, with central cyanosis and grade 1 clubbing, and variable hypoxic saturation and BP of 4 limbs is most probably the case of cyanotic congenital heart disease.
Investigation.
They have done 2 days outside in February 2024, which is suggestive of trapezoid atresia with large ASD, right to left shunt, common atrium, large VSD, left to right shunt, and severe PH or there, hypoplastic right ventricle and dilated left ventricle. Normal ear function.
Okay. So in an exam, it will not be possible to get all these components on clinical examination. In an exam, you just have to discuss what we discussed on history, what the finding implication gave us on the general examination. And then you have to discuss the meaning of each finding, like we said. What does that murmur mean, as sir said? What does the apex mean? You have to be able to tell that. Whether you can add it all to one lesion or no, it is not expected always. Right? It's a complex heart disease. You may not be able to pick it
Blood and X-ray,
up. Hmm.
which is suggestive of cardiomegaly and some motion heart.
It's book shape, no?
Hmm.
Not exactly bullshit.
So what is missing from the book? That upturned part is missing. No? So it should go a little out on that side and then come up a little. That part is missing.
CBC was done, which is suggestive of WC count of 12,900, SBO of 10.2, hematocrit is 33.9%, platelet 2 lakh.
Right.
1 year old female child, yes, complex complex. They have taken outside CVT's reference. They advise the P bending is first. But they said that there is poor prognosis in the operation is this
Poor
yes.
prognosis. Yeah. Okay. Good.
Tricuspid atresia is a pulmonary arrhythmic one.
Yeah.
This pulmonary obstruction, but the tricuspid is also
It's a yeah, it's a differential area.
it has repeated processes which are usual for that. But very rare thing. What we have learned is uh, when things don't fit in, we just go back to the history again to kind of get to the mother to say, but you said this, then again, that's a not been a major problem and repeated. Then she said, me answer to the other time, the other fellow, my other child also had a cough, so he also had a cough. So there after the things may change, which we will learn that history taking is very, very difficult. And you must spend good 80% of the time with the patient on history only. And we might have it history given by the mother reliable. Okay. I know that every mother is reliable, but you need to confirm yourself that you are reliable fact. She is reliable, but she has misunderstood something. So she is reliably giving wrong information. Remember that. Must take a note of that. Yeah. But good. You did a good job.
Good evening, everyone. Myself, Dr. Amdekar. I'm presenting the short case today. So, a 4-year-old male child, first by birth order, born out of non-consanguineous marriage, resident of Govandi, hailing from Bihar, Khan by caste, Muslim by religion, was brought by an informant being mother who is reliable, came with complaint of cough and cold since 8 days, swelling around both the eyes since 6 days, abdominal distension since 6 days, and abdominal pain and vomiting since 1 day. So, actually, the past history is very significant, so I would like to start with it. Child was apparently all right up till 3 years of age when he developed periorbital swelling, decreased urine output, and abdominal distension. He was then admitted in Rajawadi Hospital from 5th of Jan 24 to 16th of Jan 24 and was told to have some kidney disease. So from 10th Jan, he was started on some oral medication, which was taken with milk on daily basis till 21st of May, followed by alternate day till 3rd of April. A total of 12-week duration treatment was given and then it was stopped. Then a second admission happened. The child was found to have frothy urine and urine albumin was 4 plus on 20th of April and was started on same oral medication till urine report was normal, that is till 5th of May, followed by alternate day dosing till 4th of June, that is total of 4 week of duration. Then the third admission child presented with similar complaints on 11th of July, restarted with above treatment till 20th of August, and fourth admission from 4th of September to 12th of September. But this time child had hypertension and was started on some oral antihypertensive medication, which was taken one tablet twice a day. Similar treatment was started, urine report became normal, but this time while shifting to alternate day dosing, relapse of symptoms occurred, and hence the daily dosing was continued till 28th of October. Child was then initiated on alternate day dosing from 20th October. However, within 14 days, that is on 11th of November, child presented with the current symptoms, that is cough, bilateral eye swelling, abdominal pain, and vomiting and abdominal distension. So the cough was non-spasmodic, productive with expectoration of sputum, which was yellowish in color, about half teaspoon in quantity, non-foul smelling, non-blood tinge, not associated with post-tussive vomiting, with cold in form of running nose. 2 days later, child started. The 2 days later, child developed swelling around both the eyes, insidious in onset, gradually progressive to the present state, more during waking up in the morning, and gradually decreasing over daytime, followed by abdominal distension, insidious in onset, gradually progressive, associated with abdominal pain, which was periumbilical in region, dull aching, non-radiating, continuous in nature, and with no aggravating or relieving factors. Abdominal pain was also associated with vomiting. Vomitus contained undigested food particle. It was non-projectile, non-bilious. 15 had 15 episodes per day, and only one day the vomiting was present. There is no history of palpitation, chest pain, pedal edema, circulate blood cycle का history in childhood. Then there is no history of jaundice, decreased appetite, or any bleeding manifestation. There is no history of headache, no history of cola-colored urine or a change in color of urine. There is no history of visual disturbance, no history of fever or loose stools, no history of rash, itching, or known allergy, no history of any insect bite, no history of any decreased urine output, no history of repeated fractures, no history of difficulty in getting up from sitting position, and no history of burning micturition. Antenatal history. It was a non-consanguineous marriage, spontaneous conception. Registration was done in second month of gestation. Supplements taken, TT injections taken, scans done, told to be normal, and she doesn't had any antenatal complications. Birth history, it was a full term twin pregnancy. So the child was twin A. LSC, lower section, cesarean section was done in view of fetal distress. It was an institutional delivery. Baby cried immediately after birth. Birth weight of the child was 2.5 kg. There was no history of any neonatal jaundice, cyanosis, or convulsion. Child passed urine and meconium within first 24 hours. There was no NICU stay and discharged on day of life 3 on breastfeeding. Child is immunized till day. Development is appropriate for age. Dietary history. Child was advised during past admission low salt, low oil, and high protein diet. Mother was compliant with this diet. Family history. Mother, father, and two babies, which were twins. Um, Socioeconomically, the mother is not educated and housewife. Father is also not educated, driver by occupation, earns 15,000 per month, living in rented house, one room, four member. Sanitation present, belongs to lower middle class family as per modified Kupus Commission score. Um,
What is your impression? How will you summarize the history?
I think it is a renal physiology. I think it is a renal physiology because cells first start developing from the uh, uh, eye, eye later leading to abdominal dysfunction. And also associated with some body urine like something.
Your reason for renal etiology should be more strong. Okay, so starting from the eyes is what we commonly see in renal. So why does that happen? Why does it start from the eye? Why does liver disease edema not start from
And funny, the kidneys are down, edema around the eye. Okay, liver is in between, heart is above, and the edema is dependent part in the leg. So if the organ is up there, edema is down there. Kidneys are down there, edema up there.
We visualize around right so it all sorts of because of back because of
Yeah, we hepatic, it is portal hypertension, so it is visible as ascites. So it gets localized there. But why not around the eyes, or why cardiac is edema feet and not around the eyes?
The liver also may not be this ascites.
Yeah, it can
It
be.
would be only edema fluid. So why this difference? Liver, malnutrition, heart, edema fluid. Also maybe combined, but mainly dependent on. But the nephrotic fellow also has the lower limb dependent. Where is the independent of lower limb? He is also dependent. The renal process will have overall reduced plasma pressure. That is
As I tell you, so ultimately it's a play of pressure, and when it is not able to retain the fluid in the intravascular compartment, you come. So renal is a acute process, and those are chronic processes. Whenever it's a acute manifestation clinically, it quickly shows up in loose connective tissue. Whereas something which is slowly building up will take time to gravitate, although that pressures will adjust. Another example of acute collection of fluid which you see in the wards, which also you see eyes, coffee eyes, and IV fluid, overnight IV fluid, and you went to sleep. The next morning, puffiness of eyes.
such a patient that coughing because your eye is going straight into your pulmonary circuit as well. Okay. The earliest part of that pulmonary over hydration is a cough. So here eyes are getting wet when it's coughing on. So any other very more very orbital ways like just like this
Enjoy it.
enjoy it. That is fine. So this typically a nephrotic syndrome. But why not chronic nephritis? That's all nephrotic syndrome is a nephritis also, isn't it? Inflammation of the nephron. That is nephritis. So nephrotic syndrome is also nephritis. We call it syndrome because four things come together. So why in majority of nephritis, edema is not so severe? And in this fellow, edema is mostly severe. Why this fellow is mostly not sick in spite of massive edema. And that fellow with little edema is sick.
So where is the problem in the kidney?
Glomerular vertebrates.
Glomerular.
Tubules are only to pass out whatever is depleted, and of course, they are functionally very active. They decide how much to sodium keep in, how much to reduce, that's their job. So it's a glomerular. Microscopic diagnosis of a glomerular. Glomerular is a capillary structure. There is an endothelium, there is an epithelium, and there is an infestation. Can we differentiate this by history? It's that simple. Epithelium, yes. When epithelium is involved, all that is happening is epithelium is a filter. So filter is allowing important things that should have been filtered and kept back, like protein. So the filter is abnormal. If your filter is abnormal, rest is looking all right. So when filter is abnormal, lot of protein is going out. So edema, but no sickness. When endothelium is involved, endothelium causes oliguria because the not enough fluid is getting into the nephron subsequently. So you have hematuria, oliguria, hypertension, and mind disease. And in interstitium, you have only hematuria, neither reading nor related. But these layers are all microscopically present. For us to understand, we are breaking them microscopically. So then endothelium is involved, sure epithelium is also involved, and vice versa. I said that epithelial disease has severe edema, but no oliguria, no hypertension. But this time is oliguria and hypertension. What does it mean? That epithelial glomerular disease has already affected the local vein. What is the meaning of it? A complicated necrotic syndrome. Just by that. Okay? It's not likely to behave like a very necrotic syndrome.
So now come and see.
Somebody to come closer and first only inspection and tell us what you find. Look at the history. अच्छा डायरेक्टली वो करने के लिए ओके अच्छा what is the data negative for inspection first you need to show our inspection is given is it looking stick is it fluctuating dominicating is it developed well has it grown well is it nutrition all right so many things what do you think is it comfortable yes is comfortable is it analyzed the students are really minded we are lipoprotein in there we severely malnourished we severely malnourished no we are lipoprotein in there
Yes, fine. Will you call this hypoproteinemia as severe malnutrition? Is edematous, so we are assuming he is hypoproteinemia. The sir is asking, will you call this severe hypoproteinemia as severe malnutrition?
this workshop
How do you know?
imagine looking at him I want you to tell me whether he has a protein malnutrition.
So besides edema, what are the other clinical signs of protein deficiency? Clear skin is actually fat deficiency, so calorie deficiency.
Interested again. Hypoproteinemia, severe hypoproteinemia may cause severe edema, but not without skin, hair, malnutrition. And the child it doesn't look happy and comfortable. That's why first statement is happy and comfortable. Somebody is not happy. He is lethargic. He has no interest in surroundings. He has no interest in people around. He has no interest in phone. Okay. He is very interested. He answered me all my questions. That's why this is hypoproteinemia, but not more into right? He's grown well. What has been grown well mean? But here this is going on for a long time. If this is this long time, this is been growing well. Not sure. But this is going on for a long time. And even there is this going well. What will go well with this going on for a long time?
Very intermittent.
Very good. This is not a particular issue. This is intermittent. Another, this is functionally issue. That's why this is very well. Very good. But we think there are the scientists, right? Looking at them, I think he has got a chronic liver disease. Because the scientists, he has got a particular, he has got chronic liver disease. Typical chronic liver disease. So what is missing for us to call it chronic liver disease?
Icterus is compulsory in all chronic liver disease.
Icterus in a chronic liver disease is a chronic liver disease. Compensated liver disease, no chronic. It is only a scientist, only a chronic disease. But chronic liver disease is not knowledge. And what is that? Typical malnutrition is PEM, European Allergy Virus. Here there is no problem of allergy. Isolated protein department. So this is not nutritional, this is external. But so that was now this chemical on translation and progression either this is fluid or not. You will hear only. This was talking about the 6 pages. You know, better? You can learn it. And you did it well. But when you went on the lateral side, we did not hear the interview. Very good.
So what has happened now in this position? Yeah, correct. Do it on
Very good, very good. Fine. We did not want to do that, but the clinical examination was perfect. Okay. She was percussing well. When you percuss, you move your wrist. And you just she did that. She went correctly from around downward. She found the impact was she was one step ahead, up and then naturally fixed it. Right? And scientists have no shifting down. No, because you are not dull, I am asking this question. Because dull and shifting dullness is all right. And what is shifting dullness in you and me? Sometimes I'm dull, sometimes I'm not dull. Shifting. Okay, you seem to be not dull at all. That's why the question. Very cross, that's theoretical, because I have shifting happening. But yes, sometimes you get into trouble. You say, I'm not able to negotiate shifting, but I know that when there's a large assignment, large assignment, they will shift. What is shifting? Patient is shifting, fluid is shifting.
because the fluid is shifting, what else is shifting? What is the empty space? There is empty space.
Shifting, but fluid is everywhere.
Vowel.
So when the fluid is shifted on one side, the vowels which are in that fluid come up. That becomes a shifting value. Right? But in floral equations, you don't do shifting. No? So it is shifting downwards. You know, you shift the patient. Why is that?
No, not lung parenchyma. The pleural cavity is outside the lung parenchyma. And in the pleural cavity, there is a effusion. Why does this effusion not shift?
There is only one medium there, that's the fluid. There is no gas. But if you have a hydro, you know, then you shift the patient. Hydro, you not know. You can shift up the patient at home, you move, then you have a influence in their positions and change the position here. But in normal flow respiration, there is no air. But in ascites, there is no air in the peritoneal cavity, but the bubbles with air are floating into that air. That's why they shift to the other. Right? Okay. Right. But just tell us now, you can sit down. Why is you there and why I have to do? Yeah, sit down. Well, there you are. Better. Very good. Thank you. Thank you. He looks a bit short, you know. He's short. Okay. Where is he short? Must be hypothyroid. Short. You can know.
So what do you call this gate as? What? Okay.
Very good. So it would be either doing that, maybe he's genetically familiarly short, etc. So now tell me, you can sit down and tell me why oligonucleotide and why hypertension. Most of the nephrologists don't have either of them.
So contraction of intravascular volume leading to, when you're talking about oliguria, you must use these words, the apparent arterial pressure is a little less, and that is why less perfusion and oliguria. Okay. And second question, sir, asked is hypertension. Yeah, that's okay, but why hypertension? So one is prolonged steroid. Second, because of oliguria, what happens? Renin-angiotensin system is activated initially in an attempt to just refill the vascular volume, but then when it just goes on and on and on, it can lead to hypertension. Okay. Other reasons for hypertension in this child. The original pathology, no, we said this is not a simple nephrotic syndrome, the MCMS variety. So the complex ones will have focal glomerulosclerosis or whatever, mesangial they are all associated with that.
But majority of nephrotic syndrome don't have oliguria. Their intellectual volume is insignificant. Okay. Why do they not have oliguria? Because has oliguria or explained. But majority of nephrotic syndrome don't have oliguria. They are partially nephrotic. Therefore, the pathogenesis is different. But commonly, again, the second question similar that would answer together is why we said edema is peri-orbital in a renal disease because it's acute. You think on one night and early morning we lost lot of proteins, then what is acute? It's not acute. When we fooled you by saying renal is acute, okay, manifestation is acute, but hypoproteinemia and proteinuria is not acute. It's not overnight. It has been occurring. Okay. And therefore, there is another theory that it's not only hypoproteinemia and proteinuria, but also the tubular defect of retention of sodium. So sodium potassium pump is disturbed. Therefore, there is a sudden onset of a sodium retention in a child who is already losing proteins in the urine, and therefore manifestations are acute, and therefore is known as an underfill theory and an overfill theory.
Yes, how do you remember this? Underfill means what? Empty. So that is the first part which you said. The original event is loss of fluid, so empty. So body is trying to retain fluid to compensate. That is the first point. And what Sir said just now, original event is retention of sodium and water. So overfill.
Overfill. So overfill, there is a lot of urine, and there is no hypertension. The commonest nephrotic is one of the overfill. When it becomes underfill, it's a complication of the reduced volume intravascular or steroids causing hypertension or the pathology itself has crossed over from epithelial into endothelial. That's what. Therefore, the acute change in the sodium causing acute retention in a child who is already losing some proteins becomes very much at one fine morning when he wakes up. Acute manifestation of a chronic renal disease. Right? That is how nephrotic is acute. That's why acute glomerular nephritis is also acute. Okay. Because this child was running fever. He had some cold point. Would you have called it a pyelonephritis? So what's the difference between glomerular nephritis then pyelonephritis.
Anatomically, what is that?
This is pyelo, I mean,
Leptin system.
so pelvis of the kidney and down is involved. Pyelonephritis is neither edema nor urticaria nor hypertension, only fever. If pyelonephritis doesn't have any of this, glomeruli are not involved. Tubules are not involved. Outside the glomerulus and tubules, the pelvis is getting infected. Then, of course, it will spread to the glomeruli, tubules, and that becomes a chronic disease, right? Very good. Very good. But I'm amazed to see that as of your first poster, excellent. Very good. I think she did a good job.
Yeah.
Pradeep, you also did a good job. Okay. I think standing here in front of all of us itself is a good job. You look confident. And if you are ready to be confident in making a mistake, you will not make a mistake in the exam. Because your confidence will get with you. I was amazed to see your presentation was very good, so also his. And I think we had one of the earlier, you may be knowing her, I see her rarely now. But when she joined as the first poster, she looked like this. But when she became second poster, I thought she said, what is there to discuss in this minute? Okay, I don't know her name. One of these days when I see her, she comes at a time. But I reminded her of that. I used to ask her questions as a first poster, she would answer. I think you are one of those. And I'm amazed to see that you have a very strong undergraduate. You know, basics are very good. Basics are very good. Yeah, I mean, really, it was amazing to see that basics were very clear. Very good. Good job, Kenny. Both of you did a good job. And I'm proud that at first poster you are doing all this. You know, very good. But keep it up. Don't do like your other figure poster. Disappear completely from Thursday. Made me feel that ये तो क्या बच्चे जो अभ्यास दिखाता है ये तो हमें कभी का पता है it teaches something more. What is this basic? Okay, but learn the basics very strong. You are very strong. But be stronger. Okay, good. Thank you very much. We enjoyed the presentation. And keep it up. Keep it up. होगा undergraduate का बड़ा फर्क नहीं उत्तर So you were at Rishikesh. Whom did you meet there? I know. Besides Anjali there, but whom did you meet?
Chivitananda Swami was there, and he has a Paramartha Niketan which has 1,000 rooms, which is an amazing place in itself. Of course, there were our own people, our Babaji. Then I went to.
I am happy to be associated with people who went to Rishikesh.
Okay.
If I did not go.
And Jolly Greenouth and all those hospitals I covered. All the hospitals in Dehradun and AIMS I covered for our foundation. Yes, I'm in one more foundation, So in order to bring that foundation up, Ekam is already doing well.
She's very active in that. She's very active in that.
So I'm trying to bring out another foundation. Do it, make it do well. I don't collect the money, but I just see that the rest of it happens.
No, you are a dedicated worker.
So that's what I.
Because once when I was at Wadia, I convinced them to give them a small room in our library.
Yes. Yes.
Okay, yeah. But I think their work is phenomenal. Yeah. It's good to know that. Yeah.
So please send that to her, sir, because it was clicked with my camera. And there were people who were pushing her off, pulling her off. So she didn't get to talk to me, though, we gel very well.
But you have a picture with her.
Huh? I have that picture. She doesn't have.
Oh, she doesn't.
Yeah. So please send it to her.
I will send it.
And, do me one favor. She's a very sensitive soul. So she I love her as a person. And it's
You put up a word to her, she will also,
I don't have a
no, I will send her a picture that I saw her picture and I will ask her whether I could give your number to you.
yes. Only
And
that.
100% she will say yes,
Okay.
and I will confirm her number.
पल्लवी बंद करूया